Welcome back, everybody, to the We Fix Pain podcast. This is episode number 25. We've got a good one today. We've got Dr. Jerome Fryer. He's a friendly chiropractor from our great northern neighbor, Canada, and he's here because we have an important topic. We're going to talk about the bio and the biopsychosocial model. Doc, welcome to the podcast.
Thanks for having me. It's an absolute pleasure.
It's an honor to have you and your expertise and your research and that all that you've done in terms of advancing the profession forward. So thank you for being so generous with your time. The We Fix Pain podcast focuses on health and wellness related topics with a specific focus on integrated neuromuscular care. We discuss injuries to muscles, tendons, ligaments, joints, fascia, bones, and nerves that lead to pain. We address topics like assessment, treatment, and rehabilitation of acute and chronic related pain conditions. We thank you for listening and watching our podcast, and we humbly ask if you like the material, please subscribe and share. We are on YouTube and Spotify. This topic here with Dr. Jerome Fryer, the bio and the biopsychosocial model, exploring biological and physiological mechanisms in chiropractic and physical medicine and rehab. So, Doc, take me through. How did you end up as a chiropractor? How did you end up starting a dynamic disc modeling company? What was your path to get to this point?
Okay. Graduated Bachelor of Science. I was always interested in science. At UBC, 1995 in biopsychology. So I was interested in psychology right out of the gates and the biological mechanisms around psychology. So that's kind of the foundation. And then I got my Bachelor of Science degree and I was like, okay, well, there's no jobs here. Okay, what's next? Okay, what am I good at? What do I like? Who am I? Big decisions. So, everything was packed in there pretty good at the end of the Bachelor of Science. So I wrote my MCAT and I then, put that aside and I was like, okay, is this what I want to do? Do I want to chase down medicine? Do I want to push meds? Is this the most naturalistic way to help my fellow man or fellow person? I was a sports enthusiast. So I was athletic, I was a speed skater, international speed skater. So I had a lot of physicality with my life, prided myself with my body, on my body and how it functioned, optimization, that sort of thing. And then I was like, science is, I don't think I want to do medicine because it just didn't appeal to me from a lifestyle standpoint. And then I started to explore other opportunities, chiropractic. I wasn't too sure about chiropractic. I thought I was a little too soft on the science side. And I was like, no. But then I thought, you know what? I'm going to get in there and I'm going to see if I can make a change and I'm going to see if I can level up the bar for us. And so, yeah. And then all this happened. So it's been quite an adventure. But at the end of the day, I just hope that the next generations of chiros coming through are better than me and the cohort that graduated. So,
yeah, and we'll get into that here in a second. But it's interesting to hear your story of how you made the change from one path to another, and kind of how you navigated that process. And I really like to hear that you, like me, are doing our own part to kind of level up the profession, make this advancement, because I think our patients and our communities need the services that we have. And if we can have a seat at the table by understanding biological mechanisms and talking a common language, we can further impact positively our patients and our communities. So I like hearing that. So Doc, let me get into one other concept here. Spinal models. You own a company, Dynamic Disc Designs. What was the genesis of trying to create 3D real-time models to kind of educate our patients or educate ourselves as chiropractors and physical therapists and in physical medicine about these biological mechanisms? Excuse me, I got tongue-tied there. How did you get into that?
Well, it started in practice where somebody comes in presenting complaint that's related to movement, whether it's sitting for 15 minutes of progressive disc height loss, and then when they go to get up, they get symptomatic, or when I bent over and rotated this way. Okay, so does it still hurt when yeah, it hurts. Okay, well, okay, so then you go to grab I had a static model, right? With that steel rod or that bendy rod in the middle, and I would bend it and
That
I'd
thing's fused.
rotate it, and
That
all of a
thing's
sudden,
all
boom,
fused.
and then it breaks, right? The rod breaks. So I had to send it I had to find a shop that would replenish the rod in there. All right, broke it again. And the discs aren't dynamic, right? The only thing that's bending is that rod. So you're not seeing deformation. You're not seeing disc height loss. You can't see the dynamics of the symptoms. So I could share with the patient to help them understand that, okay, this is, you had to build a trusting relationship. And the only way to do that is through truth. So I kept breaking it. And then at the same time, I started because I had this interest in research. At the same time, I began a bit of a research endeavor on a little offloading strategy where you basically push your hands down to decompress the spine. So it was all kind of happening at once. And I'd move locations and my day was empty because I didn't have any patients. So I just filled it full of through doing the research. And then I thought, you know what, let's see if I can build a better model. Like, come on, don't we have anything so I bought the most expensive model, on the market from Somso in Germany. And again, it wasn't dynamic. Like you couldn't compress the disc ever so slightly, cause the foramen to narrow a little bit. Or bulge would naturally occur, or, like these things that we read in the literature, but there was no way to communicate that to patients. So I remember a turning point. I had a patient, and this is the sort of the inception behind the name of dynamic disc designs, 3D, DDD, and we do write DDD, degenerative disc disease. I had a patient that came in, and this was in Ucluelet when I worked on the West Coast. I had satellite practice. Anyways, the patient came in and said, and I was, she was I could tell she was kind of just expressionless. And she said, my doctor just told me I have degenerative disc disease, and she broke down. She started crying, like we're talking like emotional distraught. And I didn't have my models at the time, right? I had just had the static models. Like, oh, wait, hold, no. Degenerative disc disease only means that they're seeing a little bit of disc height loss and there's a little bit of water loss in the disc. Didn't matter what I said. The MD, the superior, basically said, you've got degenerative disc disease. And that's all she heard, degenerative disease. And I didn't have a way to explain to her that it was not a big deal. So that I remember always stuck with me because I didn't have the tools. I'm like, it doesn't matter what I said or what I did or how I did it. I needed a realistic model so I could nail down what that meant. And I didn't have it. And I was like, okay, you want to talk about psycho, right? The psychology?
Yeah.
Now all of a sudden, that patient's gone, right? And there was no way for me to reel her in and let her understand what her anatomy was, right? And she wasn't even that symptomatic. She had a very, like a nagging, triggering thing that occurred that happened when she gardened. So, so that always stuck with me. And that was basically the impetus behind, the name of it. Degenerative DDD, because we read it, but I wanted to talk about inspiring ways to regenerate, right? So,
yeah, and to quote something from Michael Shacklock, it's not the imaging, it's the explanation of the imaging that's the problem. And in this case, when that bomb got dropped on that patient, you have degenerative disc disease, and she didn't understand. Immediately, it created fear. So we can therefore use these tools, these biological tools, these models, not to instill fear, but to hopefully the opposite, right? Hopefully pull them back off the edge a little bit. Yeah.
Yeah.
Which brings us to the topic at hand. In my career, I started as an athletic trainer in the 1990s. Got out, finished in the 2000s. I worked in college and professional sports for a period of time, and then my real education began. I worked as an athletic trainer in a work conditioning, work hardening program. And during that time, the population were injured workers who have all these psychosocial yellow flags. And a lot of them were receiving operations on the bio for the biological things, but their outcomes were poor. There was really poor recognition at that point in time of what the psychosocial was and how it impacted people. But then it seems as pain science, which is a very important tool, kind of got propagated, folks in the physical medicine and rehab space, chiropractors, physical therapists, started to ignore or forget these biological mechanisms that can drive noise, that in some folks can lead to pain. And we became, some folks, bad pain psychologists. We're not formally trained at this, and yet folks were throwing psychosocial pain science on everybody as if everybody needed, ignoring the bio. So I want to return to that balance. The pendulum can't swing too far right to center. Why do you feel we swung too far towards the pain science and have for a generation or so ignored the bio?
I think in today's world, you can have some prominent influencers on social media that actually change the course of our trajectory. It's very interesting to watch that. So I think it just takes a few and it propagates. Like you said, it just propagates unnecessarily. And you've got a few papers that come out that say, you know what, it's difficult. We can't be absolutely certain about the bio, because we're limited with our technology, with regards to MRI, you can only see so much, and then they start referencing that and leaning into that. And right. And then they forget all the other stuff for whatever reason, all the incredible research that was done in the 70s, 80s, early 2000s, there was a lot of people studying this, right? Figuring out the bio, right? But no, it just gets pushed aside. It's old research, and it's time for the fresh stuff. And so I just think it's very fickle, right? In today's social media world, you can get some people that are really controversial, and that's attractive. We probably have already lost some people because we haven't been controversial. People have probably swept by. But if we were controversial, we're coming out of the gates with lots of emotion, that's a different story, right? That's like, oh, what's going on here? So it's unfortunate that the world has become that way, right? But that's why I think a couple influencers that have just, sort of, building their own followers in a way to be controversial. So yeah, that's my take on it.
Yeah, I think the person with the loudest megaphone, often yelling the loudest, is often the person that you shouldn't be following, because if everybody can recognize what the message is, they don't need a loud megaphone to listen to, right? The message stands on its own. That's my 2 cents, but I'm kind of one of those people. We need both. We need both to understand and recognize that pain science is valid and it can't help us, but we can't ignore biological mechanisms in doing such, because we're missing probably one of the major reasons why people are coming to us and what we are trained to help, which is nociceptive, tissue-driven pain, for the most part. That fair? That's who you're seeing in your office?
Oh yeah, no one's coming in with with somebody that's depressed, or don't mean to laugh. That's not, but you know what I mean. We're not getting. That's not chiropractic. That's not how we were trained, right? So they got back pain, neck pain. They got some sort of pain, right? And they want it gone. So they wanted us to figure it out and make it go away so they can live their life. It's not that, that's basically the market.
Let's get into some of these biological mechanisms that drive tissue noise. So you mentioned a couple minutes ago your experience with a patient that was really kind of an aha or changing moment for you. What is, or how does this degenerative cascade of the spine, how does it happen? What starts to happen? How does it begin? How does it end? And what are the implications for treatment, therapy, and rehab and patient management?
Do you want me to use the models to kind of help?
Yeah, if you can.
That, if you don't mind, because I can talk, but
yeah.
I think it might be helpful if if I.
Yeah, absolutely. There is a portion of YouTubers that watch this, and if we can get
Okay.
something to explain to the masses,
Okay.
video would be great.
Just give me a moment here, and I'll see if I can get this set up. Let's see here. How do you flip the camera around? See if I don't think you can you? I did it at the beginning here. Let's just see. How about if I switch?
You want to hold?
Yeah, I guess I could just hold it here. Yeah, it's not as
That
much
would probably
fun
be
because best would be that I can use both hands, right? But I'll come back. Let me just come back to this here. Apologize there, people. I thought we could spin the camera around. That would have made it much more interesting and fun, but I will do it this way. Okay, so you asked me a little bit about the degenerative cascade, right? We know.
Yeah. How does it start? What does it look like?
I think it starts as early as the first and second decade of life. We've seen that in the literature, right? And these things that we often don't pick up on, but annular fissures, right? Most often it's going to happen from some type of injury to the disc, right? Where you have an annular fissure. It could be small, right? A little fissure right through the outer annulus. So when the nucleus is supposed to be contained within the annulus, then it creates this barrel type of a resistance, and each vertebrae remains separated, right? And allows you some motion as well. But when that nucleus finds a way through the annulus, then what happens is the nucleus now gets dispersed into a different segment of the annulus, and the disc height comes down. So there we go. There's the early stages of degenerative disc disease. And then as that, we can use the word propagate because we mentioned that before. But now under repeated stress strain reversals, you can get delamination of the annulus. And now the disc has lost some of its stability. Makes sense. The nucleus is now in a different segment of the annulus, so it's not a nice contained sort of vessel. And we know that fluids are incompressible, so this is incompressible. So what happens is now the whole segment starts to move, and we get now this disc has been created with a little less stiffness, because when you have the nucleus now in a greater voluminous area, the disc now loses its ability to maintain stiffness. And now you start to get hypermobility at that particular segment, right? And now the facets now have to work a little harder, right? Now the facets are taking more load, bearing more load. Right? So now we get, facetogenic pain, possibly, right? Now we got shear issues. So instead of each disc, holding the vertebrae appropriately away from one another, now you've got one segment, and you don't often feel this in the early stages, right? And you're like, oh, that felt a little funny. But now you've got hypermobility, and then that leads to time. You have progressive disc height loss. This comes down. Now you can see, look at the facetogenic arthritic processes that occur in here. You can see here we've got projecting osteophyte that can come into the foramen, and now you're dealing with lateral stenosis. So it's a cascade of events that can occur over a lifetime. Is that helpful?
Yeah, that is. So typically earlier on, there's a form of an annular tear that kind of triggers this. Eventually, that annular tear leads to a little bit of dehydration, delamination of the fibers, and then a little micro instability. The body's attempt to try to stabilize it is to lay down bone, which leads to an arthritic presentation, and eventually that creates that stiffness that was lacking in the system. Is that fair? Is that a good summation?
Again, right at the end there regarding the stiffness, You said that, so the facets start to proliferate. You got hyperostosis, that sort of a process, and then that at the sort of at the end stage, yeah, when the disc height comes down significantly, then you get into more stiffness. Yes.
Gotcha, gotcha. And at what point, and I know this is kind of a loaded question, hard to predict, what point does this start to become uh, clinically, the hardest thing is if you see in an image, is this clinically significant, clinically relevant? Have you kind of been able to determine, hey, this is the point where a patient becomes symptomatic, painful, and needs help, and everything else, let sleeping dogs lie? Have we got to that point where we figured out who is what and what needs management, what needs just advice? The psychosocial portion of it, hey, you're okay. You got a little bit of a wrinkle, just kind of like you're aging. It's present, but your life is pretty good. Have we been able to figure that point out?
Well, there's so much complexity associated with, there are 56 annular fibers, right? So you can imagine the complexity of the nucleus, how it can go this way, it can go that way, it can create a protrusion where now you got a contained nucleus, you've got an extrusion. So it all depends on the case. For example, if you see an extrusion, let me grab this. That there's a good chance that will resorb. So we can talk about that. We can show the patient, you know what, look at the MRI report, look at the image, you've got an extrusion. So that's actually, it could be a positive thing. What? Positive thing? Yeah, it's better than a protrusion. Well, why? Well, because we know that about 50% of cases that have an extrusion, where it actually comes out of the annulus, that our body identifies it as a foreign substance, and our macrophages, we have a tendency to chew that up. Our systems tend to chew that up versus a protrusion, which is a little more tricky because you've got this disc that's kind of like, there's no nucleus, exposed nucleus that's going to now resorb. You've got an annulus that's basically could be abutting up against, a nerve root up against the back of where the foraminal stenosis or in the lateral recess. Oh, okay. So this is a little trickier. So I think, as we start to move forward, like Fardon in 2014 basically came out with a paper in the Spine Journal, said, okay, here's our language. This is a protrusion. This is a disc. This is a disc herniation. This is an extrusion. That sort of thing. Once we get a little better clinically at understanding the differentiation of all these disc changes, we can start to hone in and start to talk to patients and look at these outcomes in a way that makes sense, right? So every case is going to be different. It's extremely complex. Each disc is different. So you just got to bring the data together and do your best. I know definitively we're not going to know all the answers because it's just so complex in there. But if you can make sense to the patient with regards to their symptoms and when and why they come on, that's, I think, that's medicine 3.0, where we start to really nail down, look at cases specifically.
Yeah. And everybody's anatomy is slightly different as well in terms of, hip sockets, in terms of the shape of the discs, in terms of their genetic viability. And if we can personalize medicine one day, to really individualize recommendations instead of, well, here's our clinical prediction guidelines, and shoot, you didn't work. You should have, but you didn't, right?
Yeah.
I think that's, like you said, the next wave of medicine. How to get there is the open question. Doc, so what happens? One of the things that I've done, one of the trainings that I've done is some of the McKenzie method principles. In the early McKenzie method, they talked about the dynamic disc. If you flex, the disc protrudes posterior. If you extend, the disc protrudes anterior. Laterally flex to my left, disc will slide to the right. Sometimes that happens, sometimes it doesn't. Can we go through those mechanisms of why that is the case in some patients or some situations, and why that may not be the case in other situations in patients? Maybe even use some of those fancy models too.
Yeah, absolutely. So you've got to start with, okay, what are you dealing with? Do we have a nucleus? Is there an actual nucleus, or is it just homogeneous, right? Depends on the age of the patient. So if you have a nucleus that actually can move, right? Is there a nucleus that actually can move posteriorly in flexion and anteriorly in extension? Well, okay, that's the first principle. Maybe there's the viscera doesn't allow the nucleus to move, and the annulus will, it's a little stiffer. It's a totally different animal altogether. So if you already have a disc bulge, if you have a disc bulge already in the spinal space, extension, if you take the patient into extension, that's gonna narrow down the AP space, right? The anterior posterior spinal canal space. But if you have a nucleus that's extruded and there's still a sufficient fissure to allow it to resorb back into, well, guess what? There's a chance, because when you decrease the pressure, right? So when you decrease, in flexion, the pressure comes up, right? And actually in extension, the pressure will go down. So you are trying to create intradiscal, negative pressure to allow the nucleus, if there is a nucleus, to retract. So, like I said, every case is a little different. You have to explore a little bit, right? So that's why you're getting sometimes you're getting these outcomes and sometimes you're not. And you're like, well, what's going on? I'm doing the McKenzie protocol properly. Well, guess what? It's not you. It's the patient and their anatomy, and you just have to work with it, right? Sometimes for example, I had a case recently where I was doing the McKenzie protocol with the patient, and there wasn't any resolve. So I tried something different. Patient was prone, and I took the legs, and I basically did a lift with their legs like this, and I traction into extension. That was sufficient her symptoms were gone after that. So I knew that I needed to change the angle a little bit and then create this a little bit more traction, right? This coming up on your elbows, you're not getting too much distraction. You're hoping that this is enough, that is enough to create enough negative pressure within the disc. But I had to grab pelvis and pull, and I was sweating, right? With all my might. So if you've got something that, it's not working, you got to change. You got to change the formula, and you got to try different things. And the thing is with these models, I can share with the patient what my intent is, what I'm trying to do. So they understand, instead of just lying there and, boy, that feels weird. They can actually, and then they're, after the fact, if there's increased symptoms or it didn't work, they're going to say, you know what, that guy or that girl was really trying, right? Trying to help resolve my symptoms. So so anyways, does that help at all a little bit? Is that because every patient is a little bit different, unfortunately, and you have to nuance it. That's what I found.
It's always an N equals one. I have a tendency to agree that the elderly patients' disc migration is, well, let me back up here. N equals one. That being said, migration of a disc is not the only mechanism by which patients get better when you do repeated motions. It was a theory. It's a great theory, but it's not the only mechanism. In fact, in some cases, if you extend people, and the disc should migrate forward, but we can even see posterior migration because they may have a subsequent annular tear, and the normal disc processes, the imbibition of the disc, the normal disc migration is completely off. So there's theory and there's practice. So you should always follow your symptomatic baselines. Are they centralizing? Are easier for them to bend, sit, stand, squat? The physical baselines of which should follow. So there's theory and there's practice, and there's a difference between the two. But in a normal, young, healthy, intact disc, there should be predictable movement. Predictable is the key word, movement of the disc, but it never does supersede what your physical exam and your physical baselines hold. So I appreciate that, especially when you kind of went through like, well, wait a minute. I had a patient that I extended, I wasn't getting the result. I had to change the angle because they were slightly different. N equals 1.
Yes.
Doc, if we start to get into some other physiological mechanisms, what happens when you create decompression? You mentioned traction decompression a second ago. What's the physiological mechanism by which traction or decompression starts to facilitate improved physical baselines and improved symptomatic baselines?
Well, the most sort of natural thing that we already know and we can learn from diurnal variation, right? So we know that, discs plump up over the course of the night because of recumbency, which is a form of decompression in some ways. The musculature is still creating some compression, but during the act of rest, the muscles can relax and you get even more imbibitions. There's the study in Wilkie, 1999, they looked at, they put a transducer right into the disc and they saw it was in vivo daily movements of an individual. And they saw the changes in the intradiscal pressure. So really, you create a low pressure within the disc, right, by distracting. Makes sense. And then that will create a negative, just like in when it comes to weather patterns, if you get a low pressure, rain's coming in. Hey, we know that the weather's coming in when there's a deep low pressure. So it's just, basic sort of physics, right? When you get a low pressure, water comes in. When water gets drawn in through the end plates, right? Because this is charged full of blood in here. And then what happens is the nutrients diffuse through that end plate, bringing nutrients to the chondrocytes, fibrocytes, that sort of thing. So water plays a role in sort of, as a solvent for the nutrients, glucose, but it also plays a role with as an actual mechanical volume, because we got these sulfated groups within these proteoglycans that are highly charged negatively. And when you look at these proteoglycans, this is like really negative. And water comes along and, right, from an ionic standpoint, they grab on and then so the more proteoglycan you have within the disc, the nucleus in particular, the more water binding capacity it has. And the more water that can hold on to all these filaments, well, guess what? When compression presents itself, well, these things they're grabbing onto these proteoglycans and they're holding each vertebrae away from one another. So the more mass you have with regards to water. So decompression, I think, plays a role in delivering nutrients to the cells that build these proteoglycan. It depends on the, porosity of the end plates, the bony end plates. But even in, I looked at a little simple offloading strategy and I went and measured it with upright MRI in Scotland, where you actually just push down with your hands. You can self-decompress. And I was kind of curious. I had a stadiometer that I measured people's heights before and after, and their heights went up. And I thought, wow, what's going on there? Is it just the C curve is coming up, straightening out? Or is it actually the intradiscal height is, the height of the discs are coming up? So I went and measured it in Scotland using upright MRI in 2010 and had a paper published. And the disc heights went up, but they also came back down again, right? It's like the tides. So I think we use movements in our day that naturally decompresses our spine, and we don't even know we're doing it. You even have patients that present, they're standing like this, look at the scissors jack. So they're standing like this when they're talking to you, likely they're slowing down the compression as they stand there in front of you. And usually to me, that's a clinical sign. Okay, I think I know what you need. You need stability. And you need a little bit of disc height, right? So does that help? Did I explain that?
Yeah. So kind of what I've moved into the last 5 or 10 years is really trying to understand mechanism-specific pain. Who's extension intolerant? Who's flexion intolerant? Who is compression intolerant? Who needs stabilization? And if you can classify who should belong in what category, chances for an outstanding outcome go up. What you're referring to is the folks that do not like compression-based mechanisms. We can argue the tissue that's the driver of pain, but the mechanism itself you're unloading the entire mechanism. You're unloading the end plate. You're unloading the facet. You're unloading the spinal segment, the vertebra, the disc, the vertebra on the bottom. And with that chair decompression, that's what I call it. I don't know if that's what you call it. What you're doing is providing a really simple exercise to reduce the nociceptive drive to all those tissues that benefit from compression. Which leads me to, how do we know who is compression intolerant? How do we know who the person is to recommend that chair decompression exercise? How do we find it?
Well, if somebody's like I just presented, if somebody's presenting like this, I know it sounds simple, but I've seen this time and time again. Somebody that has the inability to, right? There's compression intolerance there. But you also have to be mindful, like you said, there's a lot of people that respond to compression, which I think that in itself will tell you a little instability or stability a story, right? So you have to be mindful of that. Compression intolerant, people that sit for a period of time, they have, they said, I get symptoms after a period of sitting. Not always during the act of sitting, but when they go to because when you go to get up, there's flexion often. Well, there is, right? So you've got sustained compression over time. The disc heights will slowly come down, right? And then when they go, it's like one final compression, right? They're like, oh, right? And then they go to stand up. Often it's the sets that are now imbricated, and they're having to now trying to straighten up, and it takes a few steps to straighten up. There's another clue, right? There's another clue that likely the disc heights have come down, right? So yeah, those are a few of the presentations that usually get me thinking about a compression intolerant patient.
Yeah, I'm going to add a couple more to that. I'll do a heel drop test. Come up on your toes, drop on your heels to mimic heel strike. Now your ground up forces causing a compressive mechanism from the ground up. Also, You're listening for history. Walking bothers me. What part? Oh, when my heel hits the ground. Got it. Those are also the people that don't like speed bumps. And I used to live in Chicago, and let me tell you, speed bumps and potholes, right? So when they go over a pothole, that vibration, right, can trigger that. They're getting cycles now of a compressive force in the ground up. So those are things that I would listen to. And then, like you said, they're coming in. I call it the catcher's position, or they're coming in shortstop position, hand on their hips,
right,
like that.
Yes,
yeah. That's a telltale that they like decompression. And then for me, it's pick my poison. Whether it's your exercise with the chair, hanging out in the shortstop position. If you go to the gym or you have a big tree in the back, like an oak tree, hanging, create some decompression as well. And the interesting thing is that you can even play with it. You can have them go into a little more flexion and decompression, or extension and decompression, and sometimes you'll even find those symptoms change and their baselines change, even more whether you flex or whether you extend. So it's an interesting little game that you play.
It is really interesting. And one of the little tricks that I use in practice, actually, it was interesting when I went and did that research in Scotland. I worked with Dr. Francis Smith, who was the first doctor in the world to ever conduct MRI in 1980. He took me under his wing.
Interesting.
And I was all excited about this exercise. And I'm like, okay, because I've seen it help patients. And I had I was a young researcher, just full of energy. It's like, I think I found something, right? Excited. So he's like, he kept me kind of calm, and, you got to do these protocols. So I had the patients in a stadiometer seated. So I measured their height, seated height, and then I let them sit there for 15 minutes. I measured their height again. And then I got them to do this decompression exercise 5 times 5 seconds, measured their height again. Heights went up about 6-7 millimeters, which was interesting, which I'd seen before. And then over 15 minutes, I measured their height again, and it came back down, not to the original point. Then I thought, okay, let's move you into the MRI, right? Because now let's do this exact same protocol, but we're going to do this in the MRI. And I thought, let's go. And Francis Smith, he was like Yoda. He's like, Jerome, you must lay the subjects down for 10 minutes to neutralize the disc height. And I was like, what? Yeah, you have to lie the subjects down to reestablish you got to neutralize the disc height. And I thought, my God, that's even more interesting than my exercise I'm all excited about. So I tell patients, if they can't do this or remember to do this regularly for those compression tolerant patients, I'll tell them, I said, you know what, here you go. Every 3 hours, it depends. I sometimes say 2-3 hours, depending on the case. What I want you to do is I want you to lie down for 10 minutes. You're like, what? Yeah, no, I don't want it. I don't even know. I keep working, And I said, no, I want you to lie down. That's great. That's the best exercise I've had, And I love that. That sounds fantastic. So guess what? I get them periodically replenishing that disc by lying down for 10 minutes over the course of the day. I've had so many results from that. And it was something that was shared with me when I was doing my research. And it wasn't even about my exercise. It was something as simple as recumbency. So that was a gift.
Yeah, it's always nice to be able to take the suggestions of others, especially folks that have been there, done that, and tweak your recommendations. I've had to do that too, and I've been the person that benefited from that published paper because I read that and I was like, you know what, I'm missing a mechanism that's driving a nociceptive mechanism that's driving pain in some patients. You mentioned the forward bending, and they kind of, when they forward bend, they start grabbing at their back, and that's been termed an instability catch, an instability catch sign. What physically occurs? Maybe even if we can use those fancy models, when you start to get that instability catch, what is the mechanism at play there?
Two most probable mechanisms, I'm going to say. Two is that the nucleus pushes posteriorly and now aggravates an innervated fissure. Okay, so possibly granulated, and there's neo-innervation that occurs to it. So that could abruptly cause the muscles to protect, or sure, there's more than just two, but these are the sort of the two at the top for me. Is now you've got, when you get flexion, right, and there's instability, there's shear translation. Right, so
one level slides millimeters on the other.
Yeah, exactly. So that's shear, the active shear. That's shear. Right. So when you have a disc that's lost its ability to maintain spacing properly, now in flexion, you've got shear translation. So look what happens to the facet joints. Facet joints, I'm going to do it in retro here, but you can see there's a retro. But anterolisthesis, you're going to be getting, those facets are going to be smacking up against one another. The hyaline, right, within the facet joint, and you've got the, the medial branches there. It could be a facetogenic symptom, like, oh. So when you have shear instability, you have to be thinking about a facetogenic symptom as well. Yeah, so those are probably the most common. It depends, is there leg pain that presents with it, or just back pain, right? So if it's leg pain, now you're thinking, oh my gosh, okay, maybe this nucleus has come, now it's, it's out and it's butting up against this guy, right? So likely, what do you think?
I harken back to what Stu McGill first witnessed in his subject when disc herniation was literally created, and he was tracking the subject, and they saw instantaneous micro movement of the spine, a couple millimeters. But that, like you said, that shear mechanism was something that really kind of stood out to me in how he described it. And then, the trick is, like in office, what I'll do is I'll flip my camera around. When patients start to get this instability mechanism, I'll reflexively have them brace, push their fingers into their abdomen.
Yeah.
I'll even have them squeeze something between their knees to drive core stabilization. Have them repeat the test. And if you get, that was a lot easier to move through that painful zone, and you've created a buttress for stabilization, it just lets you know they need stabilization training. You're dealing with a micro instability, not frank instability like you need to fuse that sucker, but a micro instability present. But here's the trick: if you have them increase that compressive force and it drives up their symptoms, there's a completely different mechanism at play.
Right, because I agree. I agree. Now you've got compression sensitivity because when you activate the musculature, you create a little bit more compression as well.
Yeah, yeah, and a completely different mechanism. And then opposite route: do we go into decompression, or do I just try to create like low dose stabilization, like not high dose, like basically, you're doing simple breathing exercises, because breathing is a stabilization exercise in and of itself, but it also can provide, when you're supine and breathing, in a weird twist of fate, that decompressive mechanism too. It can do both, which it's a good place to start 90-90 breathing if you don't know where to go with some of these really tough cases. And it drives down sympathetic drive too.
Yes.
So
And it gives them some empowerment because they know that, oh gosh, okay, so this is a position that creates some reduction in the nociceptive drive. So, okay, let's start with this, So, yeah.
Doc, let's flip the script here. Let's talk about cavitation and manipulation. I'd imagine you've done some work or have some thoughts based on what actually occurs when there is a cavitation, when chiropractors or physical therapists or osteopaths do manipulation. So, what happens from an anatomical standpoint, and then flip it: what happens from a physiological standpoint?
So when we talk about manipulation, I think we have to define what we're talking, like what kind of manipulation. There were some papers published that looked at flexion distraction, mobilization strategies, and the literature talked about it being manipulation. So we have to be very clear about what we're doing to our patients. I think you are talking about the high velocity, low amplitude type of maneuver that generates an audible release, correct?
Yes, sir.
And that sometimes occurs without us too. So how does that make us feel professionally, right? We'd like to think that we are the ones that elicit it when it's appropriate. It was something that kind of always, I was always questioning that. Even I graduated in '99, and we had Unsworth paper 1971 that talked about it being a collapsing bubble. A cavitation collapsing bubble that generated the audible release. And I thought, that just, to me, I was, okay, didn't make sense to me much, right? And then at the same time, in the marine literature, with the engineers, you want to avoid cavitation because it pits off steel from propellers. So there was sort of this discrepancy. I was like, okay, but we're, going to adjusting lab and we get a check mark if we make things go pop, right? So I was always kind of questioning that. I wondered what was going on. So there was a paper published in '95 by Brodeur that really kind of lended to some interesting sort of ideas on. There was an elastic recoil of the infold of the capsule. Like as you distract a joint, there's going to be negative pressure. The capsule will get involuted, and then as it hits its elastic end range, it snaps straight like this. That one kind of made a little bit more sense to me. So as I moved forward, I was polishing the hyaline surface of one of the facet joints, and I had a customer that wanted me to create a joint capsule with a synovial fold or a meniscoid, which is basically like a meniscus of the knee, but it's a smaller scale. We've got these little meniscoids within the two articular surfaces. So I was sculpting that. I was polishing the surface, and I put the two structures together, and I pulled it apart, and it popped. And I was like, that sounds just like when I'm doing that in clinic. Is it possible that maybe it's the meniscus that's lifting off, just like a suction cup release? So anyways, I contacted the University of Alberta. We ended up getting a paper published. We did an MRI investigation of my own knuckle. And what was interesting is we saw that the sound, although we didn't record it, was related to a bubble formation. So there was a cavity that formed within the joint space of my knuckles. And which was contra to what Unsworth showed. He showed that there was a formation and then a collapsing bubble. But we were able to show the bubble, and we could keep it there under traction. So if you pull it, there's a cavity there in my finger. So we could see it. So that's I think why it kind of took off and went viral. And then that was interesting, but it still didn't tell us anything about the mechanism of the sound. We just showed that it's likely not related to a collapsing bubble. So I came back to the lab, and then I went back to my model, and I did it in fluid. I put the model in fluid. And interesting, there was somebody in the University of 20, Sonder Wildeman. He was a cavitation expert. He says, "Oh, you have to degas the fluid before you do that." I said, "You got to degas the fluid? What are you talking about?" So, because of some of the models that I create, I have a vacuum chamber. So I degassed a simulant, and then I found a way to create synthetic synovial fluid. Created that, degassed the fluid, and put it in a bath of a synthetic synovial fluid, and I pulled it and it went pop, and there was the cavity. And then this is the thing, after a period of time, under compression, which is what muscles usually do to a joint, right, for stability, I was able to pull it again, and it demonstrated refractory. So I think, because it's happening at such a so quickly at about 1,000 frames per second, it's difficult to get audio and visual and to understand the mechanism, what's happening at the moment. But to me, it doesn't look like it's related to the fluid. It looks like that is just what's happening as a result of distraction with Boyle's law. So I know that there's still research to do, but basically what we can do is tell our patients that there is a gapping phenomenon. And we know that there's laxity. When we get somebody in side posture, right, often we take a contact here, right? We'd like to think that we're very specific, but, we take a contact here. Sometimes we're on the PSIS. Sometimes we grab the sacral apex. What's that called again? I forgot now. Anyways, it's been a little while. Sacral, and we'll rotate, right? There's going to be a rotational phenomenon, right? Sure, there's going to be maybe a little bit more extension, a little bit more flexion, but there's rotation. And the first joint often, you can kind of get your hand in here to be a little bit more specific in here. But for the most part, we drop on the pelvis, and there's rotation, and there's a gapping of the facet joint at L5 likely, L3, 4, if we get audible releases. Sometimes if there's too much stiffness associated with 4, it's degenerated, the disc height is just down. Maybe when you adjust, now L4 gets gapped. So, it's going to gap from the bottom up more than likely, right? Because that's where the rotational torque is coming from. Now we can talk about with the patient that there is transient within the refractory period. We know that there's laxity. There's laxity, right? You can feel it in your own finger. You can feel how there's increased laxity within the joint, within that refractory period. So there's that golden period where a patient's like, "Oh, wow, that feels really good." Keep in mind, as a practitioner, that's likely going to fade. Because once the refractory period is abated, you have, of course, during that period of time, instilled a little bit more disc height. And now you've got some movement in there, right? Do you have a question?
How long is the refractory period?
It totally depends. It's very interesting. The research shows it can be up to an hour and a half. And some people, it's 20 minutes. Interestingly, when I gap my finger, right? I got my finger. My first set of, I thought, okay, let's measure my own finger and see if I can reduce the refractory period. So I created compression with these popsicle sticks, duct tape, and I created compression. I could get my refractory period down to 10 minutes. So the more compression there is after manipulation, the refractory period decreases. When you have more laxity within the joint, I think this is where vacuum phenomenon actually, I just saw a paper this morning that looked at vacuum phenomenon within the disc. I think it's the same mechanism of what I was able to reveal in 2017 here, that there's laxity. We see vacuum phenomenon now within the disc, and you get vacuum phenomenon, joint effusion, and increased disc height because there's still enough mobility, that is a clinical sign for instability. I just got
Yeah.
published this morning. So
That
the
was my
fact
next question. Are you in some patients, unfortunately, creating a micro instability? So, it kind of Texas, like the gambler, no one to hold him, no one to fold him, right? Who should be
well,
manipulated and who shouldn't?
well, that's the thing, right? If you've got a foot that's sensitive, that's hypermobile, right? You've got a foot that's hypermobile, you suspect so. It's difficult to be absolutely certain. I do a lot of P to A provocation to see what segment may be a little bit sensitive and do that, leg extension to stabilize it to see which segment. But say, for example, 4 or 5 is hypermobile, and now you manipulate 5, right? Well, I'm getting a little bit wrong. But anyways, the level above is hypermobile, and the one below is hypomobile. Well, you get inside posture and you manipulate. Now you have increased the mobility to this segment. There's going to be relative less motion to this guy now because this guy is doing more work. This guy now has more laxity. So this guy, when you go to move, it's not all fulcruming at this particular segment. You've got this guy now has more movement because there's a little bit more motion there. So sometimes we think, we're doing one thing, but we're doing something else. But you're right. When it comes to manipulation and a patient gets aggravated as a result, right, we should be thinking about that. As likely we've instilled motion in an area that probably didn't need it, and it's good to talk about it. It's okay to talk about it. It is, people. It's your patients want to know what your intent is, what you're doing, what you're trying to do, what your clinical goals are, and as long as you talk about it, don't get all defensive. It's okay. That's what I love about these models. You can now say, you know what, this is what I'm trying to do. You understand? Yeah. Okay. So get inside. Is that sore? No. Okay. Right. So right on, exactly. When you do manipulate, you can't just think that everybody gets the same formula because it's not the case at all. And I think it's very important to watch what's happening under your nose.
Yeah, I kind of liken it to like when I first started in chiropractic school. Chiropractic positioned itself for years and years and years as the profession that provides the manipulation. Well, I got news for you. Other professions are doing it. We need to be position ourselves as the problem solvers.
Exactly.
Like what conservative tools do we have to solve what problem, and let's apply the right tool to the right patient. Because if we generate as a profession outcome after outstanding after outstanding after outstanding outcome, we force ourselves into a seat at the table for any conversation for musculoskeletal pain.
Exactly. And that's why, sorry to interrupt, but that's why I chase down this mechanism, because we have to own the manipulation if we want to lead, because that's what identified us in the very beginning. That's what got us to the table. So let's own this research, right? We've got to learn, we have to understand the mechanism of joint popping, why it is transient symptoms, why it improves some people, and why there's some people that are non-responders. We have to own that too. We just don't have to put our head in the sand and say, you know what, maybe next. We got to own it all. And that's why I drove hard to understand the mechanism so we could all sort of teach our patients about what we're doing to them.
One of my fascinations the last 5 years, and it's funny that we're having this conversation today, probably in about 2 hours, my mother-in-law will be getting a procedure done called Intercept. Intercept is where they drill into the spine and inject into the sinovertebral nerve because she has compression intolerant spine. Standing, walking, extension drive her nuts. But when she's completely sedentary and sits, too much sitting also drives her nuts. So 2 to 3 hours from now in Phoenix, Arizona, she's going to be getting this Intercept procedure where they drill into the vertebra and inject pretty much an agent that deadens or burns that sinovertebral nerve that supplies the end plate. So for the last 5 years, more and more research has come to the end plate. So take us through, what are the unique characteristics of the end plate? What drives the end plate to be symptomatic, problematic, and do we have anything in the arsenal conservatively, minus this procedure that's not conservative, to make the end plate less likely to be a nociceptive pain driver? So take us through, what do you see in the end plate? What is the end plate?
So it's interesting. About 10 years ago, I was at the North American Spine Society meeting, and I brushed up against the guy that,
In Chicago this year. I'm thinking about going.
oh boy, yeah, this is going to be it. It's so much fun. It's amazing. So I rubbed up shoulders against this guy, Stefan Becker, and he is a leader in this. He's the one that discovered the Hans or the basivertebral nerve. It's the basivertebral nerve that you're talking about. And he was telling me this is how they
got my anatomy wrong.
Yeah, and I got a model in my showcase here of the basal nerve, but I got to go get the key to get it. And it's a nerve that that comes through the Hans venous clefts, and there is a triangle because the Hans venous clefts come through. So there's a triangle, and it's called Becker's triangle. So he was the one that discovered the anatomy, and he said, "Hey, Jerome, you got to build a basal nerve model." I was like, "What?" Yeah. So I worked with him back and forth. This is what's interesting. This is where it was discovered. So they were doing kyphoplasty, and they were finding that some patients were getting a response from basically putting a cement into the vertebral body to increase the vertebral body height under compression problems, compression fractures. And it was the curing of the agent of the bone cement that it would have an exothermic reaction, and it was burning the nerve. It wasn't the structural change of the vertebrae that were per se that actually was improving the biomechanics. It actually ablated the nerve, and they didn't even know it was ablating the nerve. Yeah.
Wow, I did not know that because I've had patients in the past with marginal success for kyphoplasty, and the ones that did, you're like, well, what gives? To the point where some doctors for a compression fracture won't even recommend kyphoplasty. They'll just say, decrease your symptoms, live your best life once the symptoms are minimal. But I didn't know that was occurring.
Yeah. So they go through the pedicle. So here's a model here. I'll just to show you. So they go through the pedicle. Okay? So this is a fusion model. It's a soft fusion, actually. I had a company to send this to me, but you could see this. But I just want to show you the root. So they take this root, right through here, right? So they go through the pedicle into here. And the basivertebral nerve, basically you go to the center of the vertebrae, and the nerve branches up like this, up to the end plate, and then it branches down like this to the other end plate. So there's sort of an epicenter. So it comes through through here, through the Hans venous clefts, which are these little holes in here, and they come out. There's a little triangle. So the nerve kind of goes from, it's kind of hard to show here, people, sorry about that, but there's a triangle. There's two little holes there. So they go this way. There's the triangle. That's Becker's triangle. And what we're talking about in the center of the vertebrae here. But this is the root. They go through here, and they go in there, and they basically, it's like an ablation. Just like they do medial branch blocks. And they're, and then they test to see if there's a symptomatic improvement, and then they go in there and they do rhizotomy. So similar to rhizotomy, it's just the location. So end plates, we know, can be sensitive, right? I just saw a paper 3 days ago where it's more likely that the end plates are going to be damaged as a result of cyclic compression. Cyclic compression, like going over the speed bumps that you talked about, is more likely to affect the end plate and create, the Schmorl's nodes or mortic changes or inflammation with them, those little trabeculae, you get those little microfractures, and then the recovery. And that's the innervation. The basivertebral nerve comes within the vertebrae and innervates the end plate. So I wish all the best to did you say mother-in-law or your mother?
Yeah, mother-in-law's today, and it's been a long struggle. And then finally, she came to me, and I'm like, okay, I'm going to play doctor, not son-in-law. Let me take you through. And I assessed her. I'm like, yeah, compression intolerant spine. And I'm like, I love my mother-in-law. She's not going to change her habits, like eating habits, physical habits. And I was like, you've been to physical therapy, chiropractic, you've been through everything right now. There is one other option on the table that's invasive but non-surgical, and this is it. So she's lined up for intercept it's 11:15 right now, 1:15 Central. So what is that, 11 something Pacific, to have the procedure done today.
Yeah, and you assessed her, and there was compression intolerance?
Yeah, heel drop test
Okay.
positive. You go over a speed bump in a car or a pothole, it drives her nuts. Sitting, can't sit more than 35 minutes. Walking feels better, but 35 minutes of walking, she starts to have problems. So, like, and then you load it up with an MRI and you see bone marrow edema and motor changes, and you got compression intolerant spine on your hands.
And it's quite
And
obvious
then we
which.
just sent her for Well, we sent her for two opinions because I told her there was potentially a procedure, and she's like, "I've had injections in the facet. It's negative." I'm like, "Great, that's part of the diagnostic criteria to get Intracept approved." And so I don't want surgery. I'm like, "You're not a fusion candidate, and you're not a discectomy candidate, and you're not a laminectomy candidate. You are a candidate for what's the nociceptor driver, which is getting it into that basic nerve." And there's, to my knowledge, one procedure there. And I had her do some self decompression, multiple times a day, and it provides 5-10 minutes of relief. And I'm like, yeah,
Okay.
that you're compression
Yeah.
intolerant,
Yeah. Right. Okay.
and
Five,
we
ten
don't have
minutes.
enough to reduce that nocceptor drive. You can't be doing decompression exercises 5 or 10 minutes every hour for the rest of your life. Every
Yeah.
2 or 3 hours is realistic. There's a longer way of doing it. So
Yeah. Yeah. It's too far gone, right? It's now needs to be just,
yeah, it's too far.
it's like a root canal. That's the way I look at it.
Yeah,
Yeah. No, it's
yeah. Real quick, we're gonna wrap this up here. So, three big takeaways, Dr. Fryer. What are your three big takeaways that you want our audience to know about?
be curious, right? In practice, I'm wondering who's watching this, maybe the newer grads or newer people that are just getting started or those who've been in for a while. Be curious. Don't get lazy. That's a tricky one sometimes, right? Because you get tired and you get a little lazy, but stay active, stay engaged with your patients. And everybody's different, unfortunately. There are some groupings, right? There are some groupings, of course, right? And you can kind of cruise with some of them. Yeah, it's been quite a ride, and I enjoy every minute of it.
What's upcoming for you from a teaching standpoint, from a research standpoint, from a collaboration standpoint? What's in the hopper for you?
You know what? I've backed off of research because it's difficult as a practitioner. It really is because, it doesn't pay and you got to pull money out of your own pocket and you're not in it. You can't be in it thick, right? So I've backed off. That's fine. I've got a little device that I've developed to help measure perceived pain in patients. They hold it in their hand. And so I'm developing a bit of a product to give us some numbers. We want some numbers during the act of care, and it's called the pain meter. So there's going to be a paper published.
Pain pressure threshold?
Yeah, but looking at it in a
Yeah.
graduated way, right? Instead of just pushing on somebody and say, when is it a threshold for you? Well, that's graded. Right? I don't know why we're looking at a threshold because really, there's nuances within there that I think we can extract data from. So yeah, I've got that North American Spine Society meeting. The models are doing really well. People are loving them because of their detail and and it helps patient care and their education. And you know what? I'm just enjoying life. I'm kind of the tail end of my career. It's I'm learning just, I can relax a little bit here and have some fun. Anyways.
You can do a motorcycle trip around Vancouver Island.
You're right. Exactly. Yeah.
You should. You should. All that hard work, all that the knowledge you passed to all the rest of us and made our careers easier and better. You should take a motorcycle trip or two.
I hope so.
So, where can people find you? People have questions about your products or anything in this podcast that kind of caught their attention. Where can people find you?
I think you can just type in Jerome Fryer and put in whatever you want, and behind there will be anything you want. I hope not, anyways. But Dynamic Disc Designs, I've got DR Fryer, I've got Dynamic Chiropractic Clinic. There's my pain, and my email is you can use DRJ Fryer.
Doc, I want to thank you for your time. Thank you for your expertise. Thank you for educating my generation and then subsequent generations with all you've done. We appreciate you. I'm Dr. Dino Pappas from the We Fix Pain podcast. This is Dr. Jerome Fryer, and we are signing off. Thanks, Doc.